Okay, hello everybody. My name is Neil Andrews and I'm the editor of the IASP Pain Research Forum. I'd like to welcome you to today's virtual seminar, Ask Me Anything, featuring Dr. Kathleen Sluka. At the outset, I'd like to thank the Mayday Fund, which has provided a grant in support of the seminar series. And I'd also like to thank the Center for Advanced Pain Studies at the University of Texas at Dallas, which has also provided a grant. In terms of our format today, it's pretty straightforward. You can ask Kathleen absolutely anything you like. You can submit your questions at any time. All you need to do is type them into the Q&A area of your Zoom window. And so we have an hour of questions, so we really want to hear from you. So without further ado, I now have the pleasure of introducing our moderator, Dr. Ruth Chimenti. Ruth is an assistant professor in the Department of Physical Therapy and Rehabilitation Science at the University of Iowa. She received her clinical degree from Washington University in St. Louis and her PhD from the University of Rochester in New York. The long-term goal of her research is to improve care for individuals with chronic musculoskeletal conditions through improved evaluation and treatment of localized and systemic factors contributing to pain and disability. And her current work is focused on use of a biopsychosocial model to better understand pain mechanisms in patients with Achilles tendinopathy. She also did a postdoc with Kathleen, so she's a great person to have here today to moderate. Also, I forgot, I just wanted to go over a couple of slides on the screen here just to let you all know that IASP has a couple of virtual education events coming up in May. There are sessions on COVID-19 and pain, which is free for IASP members and non-members. And next slide, please. We also have the IASP Virtual World Congress coming up in June. And the World Congress is a great way to get education with tons of plenary sessions and workshop sessions and CME. This is free for IASP members. And next slide, please. We also encourage you to become IASP members. There are lots and lots of benefits from getting access to the journals, pain and pain reports, to grants and funding opportunities and so forth. So we really encourage you to join. So now, sorry for that. I now want to hand it over to Ruth. Ruth, thanks so much for moderating. It's really great to have you here. Please go ahead.
Hi, Neil. Thank you so much for the introduction and for the invitation to moderate. I have been looking forward to, I now have a legitimate work excuse to sit around and talk with Kathleen for an hour. So this will be fun. And also, as Neil said, I see some people are already putting in some questions into the Q&A. So please continue to send those. That's great. As an introduction to Kathleen, I wanted to highlight some of the things about her that I find most captivating that may inspire some additional questions from you all as well. So she is a clinician who became a basic science researcher. So she received her physical therapy degree from Georgia State University and then got a PhD in anatomy from the University of Texas Medical Branch in Galveston, and then did a postdoctoral fellowship with Dr. Willis. And she is now a professor in the Department of Physical Therapy and Rehabilitation Science at the University of Iowa. She is a translational researcher that spans the full spectrum. So she does basic science work with animal models of widespread pain, all the way to she is currently leading a pragmatic clinical trial looking at the effectiveness of TENS for people who have fibromyalgia on a and just kind of give another overview of her research. So her research focuses on the neurobiology of musculoskeletal pain, as well as the mechanisms and effectiveness of non-pharmacological pain treatments. On a more personal note, she is a mom who achieved tenure with kids in the house. And so I was doing my postdoc with her. That was always helpful to get her perspective in terms of trying to maintain that balance between home life and work life. And then I see some people already know this, but Kathleen, in addition to being an amazing scientist, is also a very talented artist as well. So many of you have probably seen her work featured on the cover of Pain. And so that's another really great piece. Okay, so let me start with a question. Kathleen, I know that when I was a postdoc that you really encouraged me to join the IASP and apply for funding and scholarships. And there are a lot of potential societies that people can choose from to join and become members of. It seems like the ISP has been a really good fit for you in your career. You served on committees, task force, society boards. Could you talk a bit about kind of how do you find that ideal fit between kind of your research goals and finding a society that matches with that?
Right. So, the IASP, which is the International Association for the Study of Pain, made a lot of sense to me because I study pain, and it is very, very multidisciplinary. And as a translational researcher doing both basic science and clinical research, as well as being a clinician as a physical therapist, it met a lot of needs that I had in my research, in my career goals. So, going to the World Congress, we were just talking about this before we started, it's just a really fun place to be. I know we're all missing our on-site meetings, but when you get to the World Congress, you get to meet all the leaders in the world in pain research. You get to meet new researchers doing things that you've never heard of before, and you get to have a lot of informal conversations with them. And I have been involved in this organization from the time I was a postdoc all the way to today, and I have served and volunteered to be on numerous committees, and it's a really great place to get involved because everybody's voice is equally heard. There's no barriers to being involved, and they always need more volunteers. So if you are interested, if it is something you're interested in doing, go ahead and volunteer. It's just a wonderful place to be for that. And of course, you all know that we also hold the journal Pain, which is the premier journal in the field. And I'm also a section editor for that. And it's a great place to publish your best research in pain. So I have published a lot, and they're very nice to take my artwork on the cover as well. So that's kind of fun.
Great. Okay. So my first question for you from the people who are here is, so sometimes clinicians this question is about neuroplasticity in chronic pain. So it seems that clinicians are now interpreting this to mean that all long-lasting pain is due to neuroplasticity and not associated with tissue damage. She works with patients who have Ehlers-Danlos syndrome, which is a chronic connective tissue disorder. So they do have persistent tissue damage. How can we distinguish long-lasting pain due to chronic tissue damage with chronic pain that is primarily due to neuroplasticity?
So that's a really good question. And we start thinking about pain and it has to all be due to changes in the central nervous system, or all has to be due to changes in the peripheral nervous system. I think most pain has a little bit of components of both. And neuroplasticity doesn't mean central nervous system sensitization. Neuroplasticity can occur in nociceptors. Neuroplasticity can occur anywhere within the nociceptive system that would drive pain, but you also get long-term changes in other structures. Lorimer Moseley uses a term that I like called bioplasticity, and really the whole system has plasticity. So you might have changes in structures that may not be associated with acute inflammation, but you might change which collagen is laid down, say in an Achilles tendinopathy, and that might change how that would interact with, say, the nociceptor, or the nociceptor itself might have an upregulation of ion channels, which might not be related to tissue damage, but might be there anyways. So I think we just have to think very broadly, and I do think that many people probably have a combination of both some peripheral components at the tissue level, some nociceptor components, as well as some components in the central nervous system. Detecting those, on the other hand, is incredibly difficult. Which ones are which. We have ways to kind of detect the central sensitivity, but detecting the peripheral ones seem to be a little bit more difficult. And I think that's just where the research is going. We're trying to figure out the best methods to be able to assess what component of a person's pain is coming from something where I need to address it at the periphery, and which ones are coming from things I need to address at the central nervous system or the psychosocial components. And I think that that's where we are now in research, and we're going to get there. But we've at least come to the idea that we can recognize some of these things and be aware that there's probably multiple components to every individual's pain experience.
Great. So thinking so I have another related question about pain mechanisms, and now specific to the population of people who have fibromyalgia. And this question asks, what can we do best as patients to help ourselves?
So as a person with fibromyalgia, one of the best things you can do is learn how understand the disease itself, learn how it changes in your own body, and how under certain circumstances, you know when you've done too much, when you need to rest, and when you need to be active. One of the most important things that someone with fibromyalgia could do is to make a commitment to stay physically active, because that is probably the most important and effective treatment, but with the realization that you may not be able to do that every day, or if you're having a particularly rough day, it's okay to take a day off, just so long as you don't take 2 weeks off, right? So taking it and understanding how to pace it and how to use other treatments to help manage the pain so you can maintain an active lifestyle, because we really know that being active probably helps you more than being inactive, and just learning what your barriers are as an individual. So it's really about learning how to self-manage it on a day-to-day basis, and learning those tools that will help you do that.
Great. And then this is also related. So this question is about the reviews that you have published about exercise, potentiating the pain modulatory pathways descending from the brainstem. There are numerous techniques in physical therapy, from invasive techniques to CRX massage or high intensity TENS, that consist in inducing pain to relieve pain. Is it plausible that these techniques could be more effective in physically active subjects? Should we reduce the use of these techniques in sedentary people?
I think that many of these techniques we should probably just use. Most of them are relatively safe, low harm, and we should try and figure out what works best for each individual, because no one treatment works for everybody. And in fact, no matter whether it's a drug or a non-drug treatment, only about 50% of people will respond with a significant reduction in pain to any one treatment. So we need to be aware of all the treatments that could be used to modulate pain, and pick the ones that work best for each individual, and understand which ones are out there that have the most effectiveness, the ones with the research to back them up, and use them first, and think about what works for each person as an individual basis. If we can begin to figure out what predicts who will be successful to which treatment, that will help us to pick them better. And we're really in the early stages of that research. So we just did a study on TENS, and we were able to show that the best predictor of long-term outcomes of the use of TENS in individuals with fibromyalgia is whether or not they responded with a small reduction in pain to the first treatment. If they responded with less than 10% reduction in pain, they weren't going to get long-term benefits. So I think as we start to think about who's going to be the best candidate for each treatment, we need to begin to think about how we would pick that one. But I think any of those techniques we should use based on the evidence and the strength of the evidence, and then go down the list from there. Some of them have better evidence than others.
Great. So this next question actually talks about how you've been following your basic science research on the effects of TENS in animal models, and how it's really filled a gap in the literature on looking at how TENS works to provide analgesia. Yet notice that some clinicians are still reluctant to use TENS in practice. So I guess, why do you think that is, and what barriers have you noticed, and how do you think you can alter that in terms of translation?
That's a really loaded question, because that is something that we too I have been struggling with is changing practice. You know, how do you take something that we know is effective, we know is low risk, with equivalent efficacy to a drug, pharmaceutical treatment for a condition, and get it back into practice. So part of the reason physical therapists don't use it because they kind of think of it as a passive treatment and we want to make all our patients active. I consider it an active self-management treatment because the patient has control and can use it, and they can use it and works best when they're physically active. We've done some studies to try and implement it into primary care practice where most of our chronic pain patients will go first before, and only about 20% of those are even referred to physical therapy. So when you think about it, you know, shouldn't we be putting this into all of those steps? And there's a lot of barriers. There's the barriers about people not knowing how to use it most effectively. There's some biases that we don't think it works because there's been some poor literature out there that says it doesn't work, but those aren't great studies. And so I think it's just about changing the mindset and getting the message back, and it just is going to take time. And I think you've heard the deal. It takes 10, 12 years to get an effective treatment back into practice. And I think that's where we are now. There is some uptick, but we need more. And we just need to get the word out that it is an option for people. And now this over the counter should make it a little bit easier because people can buy a unit at Walmart and use it for, you know, less than $50.
Great. Okay, so this question I found intriguing. And so clinicians find it difficult to explain pain mechanisms and terminology to patients as part of a patient's education and treatment. Would you recommend a specific piece of art or artist to help clinicians explain pain? Or would you be challenged to make one? I hope it's not a silly question. So anyways, I like this one.
Yeah, you know, art is great because you can really show the principles of the science without getting people in the weeds of what is a nociceptor and what is a nociceptive neuron, and we don't have to use all those terms. You can show them the art. So of course, you know, a lot of my art itself has been wrapped around pain because that's what I study, but it's also wrapped around just what is a neuron and what is a nociceptor. So I would just encourage people to go out and find things that are simple and easy to use. I wouldn't recommend any one particular piece of art per se, but rather to use a series of them as you go through different principles. I actually use them teaching physical therapy students as well to show them, you know, this is a cross section of a nerve, and this is what a nociceptor looks like, and this is what a large afferent fiber looks like, and these are the ones that transmit your pain signals. And sometimes, yes, I use the word pain signals, even though we know that that's a concept at the cortical level, because when you get down into patients and you're trying to explain things to patients, you have to get it on their terms. If you start using words that are too difficult for them, you'll lose them immediately. So having pictures and having graphics, and there's some great videos on the web too that do a really nice job of explaining pain. And I won't highlight any one, but there's several of them out there that there's been some systematic reviews on which ones have the right messages that I think are really fun. But I think that you can go out there and use all kinds of art resources to help educate your patients, because you know, you got to make it fun and exciting for them, or else you'll lose them. And I agree with you. It is hard to just use your words and not have graphics in front of you. Ruth's done some of that in her research, actually, where she's tried to make booklets that are patient friendly around the pain terminology and pain explanations. So she might have additional information on that.
Yes, finding a good image is always a challenge. But I will also say though that I specifically joined Twitter so that I could follow Kathleen's artwork because she'll often post them on there. So anyways, that's another recommendation for that. This question comes from someone who is a new PI focused on drug discovery and pain. They also happen to have fibromyalgia. And so they ask, how do you manage to maintain a high productivity as a PI while also maintaining, your energy level and physical health?
Oh, that's a really good question, because I understand you have fibromyalgia. I also have rheumatoid arthritis. And so I have to have the same conversation that you're having right now with myself on a regular basis. I think you need to know when you need to quit. I have always been really good about separating work from home. And so most people know I don't work on the weekend, and I never have from the time I was a graduate student till now, except for a few grant deadlines along the way occasionally. I have routinely quit the workday in time to at 6 o'clock at night. I rarely work in the evenings, but I'll get up and I'll work really hard during the day, and I know when to take breaks. Oftentimes you also know you need to get up and move around a little bit during the day and take a few breaks during the day. And I think it's about finding out what works best for you, but also knowing how to separate work from home, because I know that after a certain number of hours per day, I'm no longer productive. That's it, I'm done. I could sit in front of my computer and play around for 3 hours and I wouldn't get much farther. And you need to know when that is and just quit. And when you come back the next day, you'll be more energized. So sometimes it's not about working long hours, it's about being productive when you are there, sitting down and making a list of the things you need to get done that day and checking them off one at a time as you go through and staying focused. So there's a lot of time management in there, and there's a lot of knowing when to quit your when to quit and when to go on. So I think, and you have to figure out what works best for you. So it's a great question. And it is something that I think every scientist struggles with a little bit. I also need to take breaks. And when I take breaks, I get to go do painting. So, that's fun too. And that helps clear the mind from the constant barrage of information that comes in to my head on a regular basis. About some experiment we're doing, and I just can't get it out of my head. And sometimes you need to clear your mind enough to do that. So, people exercise, I paint, I exercise too, but the painting is the real way for me to clear my mind.
That's awesome. Yeah, there's actually a question here about, do you think that art informs, enhances, or stimulates your research? If so, how? So it sounds like that's
yeah, it's a really big stress reducer. I think just understand, it helps you think about the bigger picture a little bit, but it also just makes you improve your creativity in some degree. So of course it does always interact.
Great. So there are a number of questions about people that are interested in your advice on obtaining research funding. So from a few different perspectives. One person studies physical activity and fibromyalgia. Another person is studying teaching and learning in terms of being prepared to teach patients about pain. What advice do you have for where to look for funding? And then also what can you do in terms of increasing your chances of obtaining NIH funding as well?
Okay, so I'm going to tell you the little known secrets. My secret is you have to be persistent and you have to submit a lot. Most people do not get every grant they apply for, right? My success rate is about 20 or 30%. I don't get them all, right? I got lucky in the last couple of years, but it's not always happened that way. So I think what you have to do is look broad for wherever you can go for them. So usually a university has a sponsored programs, and they have kind of a listing of grants and grant mechanisms, not only at the NIH, but there's a lot of private foundations as well. The IASP has research grants that you can apply for. A lot of foundations have research grants you can apply for, like the Arthritis Foundation. So you go look for all of those and find one that matches. And then the key is to get lots of help and lots of input while you're in the writing stages, so you get your specific aims really nailed down before you do anything else. And that might take you a month, it might take you 2 months, it might take you 3 months until you get it just right. Once you have it right, you can then write the whole thing. But it's really important to make sure you get feedback from lots of people. But the most successful grants, I think, are those who really probably are using a team approach with experts to fill the gaps and the holes that we don't have. I'm really big on collaborative research, and I think that we can't possibly know all we need to know. And so going out and find the experts to help you get to that point is really useful. So, and just as far as NIH, you just have to be persistent, look at their mechanisms, and really make sure you understand how those grants are written and how they're presented, and get some examples from people. People who are willing to share their grants, so you have a template to work from.
That's great, thank you. And so this next question is, you've really been a pioneer in basic science research applied to physical therapy. How did you arrive at this field of research originally?
So my history goes back a long ways. I got my bachelor's degree in physical therapy, so that was a long time ago. Nobody can do that anymore. So lucky for me. And so then I was working in the clinic for a number of years before I went back to graduate school. But in the clinic, I knew the great majority of my patients were patients with chronic pain. And those who didn't have chronic pain all had acute pain. So pain was a big issue. And we knew that back in that time, but we didn't know how to treat it. We didn't really know a lot about the mechanisms. That was in the 80s. So that was a while back. And so I ended up going back and getting a PhD in neuroscience and anatomy because I wanted to have a better understanding of the underlying mechanisms and what was happening in those patients. And then it wasn't until I got to my faculty position that I really combined those two things and really started to think about, what did I see in the clinic? And we don't have any good animal models for that. We need to figure out a better animal model so that we can look at those mechanisms. What are the treatments? We have all these treatments, but we don't know how they work. And maybe if we knew how they work, they'd come back. So I spent a number of years actually thinking through, what I saw in the clinic and trying to apply it back into the lab. And then from the lab, we start applying it back into the clinic with better tools and with higher quality research so that we could make some real statements in the end. So I think it's all kind of an evolution over the years. When I started, I was a basic scientist. I got my training as a basic scientist, and I didn't do any clinical research for probably 10 years. And then I decided that in order to get to the next stage, I had to add in some new skill sets. So I collaborated with lots of people who knew those skills and was able to build a more translational research lab. But I think it was always a little translational because I think your physical therapy informs the research questions a lot. And what you see in the clinic can be informed by that in many, many ways. And it changes kind of what you think is important. So you try and keep your eye on the focus of what was important to the patients. And now that I don't work in the clinic, I actually will talk to patients and people who have the conditions or whatever it is I'm studying, and just kind of get their perspective on where they are today and what's important to them and what's important to, what's their biggest symptoms and what's their biggest problems and where they would like to be, so that you can keep your focus on what's important from a clinical perspective, even at the basic science level.
Great. This next question. What do you think are the key reasons that we do not have more women leaders like you in pain research? What can be done to increase the female role models at your level of achievement and visibility?
We just got to keep getting more women in. And we need to be, I mean, I think this goes to being open and accepting and providing adequate resources to women, to diverse populations, to improve improve the help that they have on a day-to-day basis. Because this isn't an easy job, right? This is a really hard job. And there's a lot of time-consuming portions of it. And early on, most of the in neuroscience, a lot of the women at Iowa would come to me and they talk. They may not have been my graduate students, but they'd want to know, is it possible to have a family and be a scientist at the same time? And I kept saying, well, yeah, it's possible. I had a baby as a student. I had a baby as a postdoc. Yes, it's possible, but you gotta figure out how to get the resources to help you. And I think it would be helpful for institutions to recognize that, and they have started recognize that. So, you know, back in my day, there weren't necessarily childcare resources for us. There weren't, I got 6 weeks off for my children after they were born. There weren't a lot of, they still had meetings at 5 o'clock at night or 8 o'clock on Saturday mornings, which we had to change. So making the environment conducive to family. And I think as more men are also actively involved in their family, that this helps a little bit too. And just figuring out how to make resources available, how the institutions can help support that. And then we got to train them and make sure women know that this is a great career. It's a wonderful path. You actually have a lot more flexibility, certainly more flexibility now than when I was in the clinic. I was able to go to all my children's school events. I just could leave and go do that and do some work later. But when I was in the clinic, I couldn't take off. I had a patient in there and you couldn't do those same things. So it actually has a lot of flexibility, and it is fairly conducive. And we just need, in today's world now with Zoom and the ability to work from home, that's easier too. Because when your kid is sick, you're not off work for a day. Back in our day, that was what happened. If your kid was sick, you didn't actually get to work. Or I just had a bag full of papers I would take home with me and read. But you couldn't do a lot of stuff because we didn't have those capabilities. So I think it's all about providing a supportive network for more women and being aware that we just need more. We need to get them in, we need to hire them, and we need to support them when they're here and keep them in all the way through. And I think that's changing. Our department now is 50-50 women and men. So that's pretty cool. And when I started, it was nowhere near that.
Okay, so the next question is a little more clinical applied. So there have been several questions about how do you best use TENS? And first of all, do you have recommendations on resources that can be used in terms of correctly applying TENS? Are there good or bad ways to use TENS? And do you see patients develop a tolerance to TENS?
Oh, such great questions. So yes, over the years, we figured out the answers to most of these questions. So resources for correct ways to apply TENS. We actually did an implementation study in primary care here at the University of Iowa Hospitals and Clinics, and we made videos and patient handouts, and they are free and to anybody who wants them, and they are posted on the University of Iowa Hospitals and Clinics website. And you can just Google UIHC TENS and it pops right up. And I use those. So I had to give a TENS unit to my dad for some pain a couple of months ago. And I sent it to him. I said, now throw the directions in the garbage can and go to this site and use this. And he's like, oh yeah, that makes all the sense. But before he did that, he had to use the directions from the TENS unit anyways. And he called me complaining that he couldn't understand how to use it. So I think we've made some resources. most of the booklets that come with the units are not so great. The best ways to actually use it, and this is from years and years of research, which we can share with you later offline if you send me an email. But we think that if you mix the frequencies between a low and a high frequency mode, and many units have this nowadays, that alleviates tolerance and provides the best effects. So we've shown continued efficacy for at least 2 months with the mixed frequency. You have to apply it at the highest possible intensity that they'll tolerate that's not yet painful. So we call that a strong but comfortable intensity. And the best place to apply it is probably surrounding the site of pain. And if that doesn't work, say in someone with fibromyalgia, you just put it on the spine, either the lower back or the upper back or both, and apply it to those sites. So those are really the keys to successful implementation of TENS clinically. And then lastly, it works really well when people are physically active. So it works to reduce movement evoked pain. So having them use it when they exercise, when you're active, when you go in the grocery store, when you're taking a walk, that also helps provide the best effects. Not when you're sitting watching TV. It's probably much better when you're doing things. So those are the key principles to application.
Thank you. So this next question is, it could be argued that opioids are prescribed and administered too generously. How can we instigate a culture of a more holistic and multimodal approach to pain that routinely includes integrative and non-pharmacological therapies?
Well, we have to have a culture change, right from the beginning. We just need, from the time somebody walks into primary care, to have non-drug, non-pharmacological treatments kind of be thought of as the first line treatments. And they are part of clinical practice guidelines already as first line treatments, particularly exercise. And we need to start with changing the culture and getting better education at the medical school, the healthcare practitioner schools, the PT schools. Everybody needs to have better education within their schools so that we're getting a group of individuals that comes out and knows how to practice in that kind of multimodal, multidisciplinary way, using the low risk non-drug treatments first and moving up the scale, and that opioids would likely only be used for chronic pain as a last resort. And they wouldn't be used hopefully on a long-term basis for most individuals. There'll be some individuals where they're going to need to be used. But if we start early on with a change in how what we do with people from the start, and this is, some of the things we've been working on and trying to change practice, is to get that into the day-to-day culture. So, making sure that everybody's educated, everybody understands that, and we get through those processes. But it's going to be a multi-pronged approach. And the last approach we have to do is to really get the public educated on, oh yeah, I have chronic pain. I know there's these active management principles that I have to do in order to deal with my chronic pain. So everybody who has cardiovascular disease knows they have to exercise and eat right. They already understand the risk factors. And we need the same ones to happen for chronic pain, that they know they need to exercise, they need to use some non-drug treatments, and that I probably wouldn't go down this route as my first choice for opioids. So it's really about changing from the largest levels at the public to the healthcare practitioners on down to just day-to-day practice. So there's a lot of levels that we have to gear that to in order to make that change. But I think it's slowly happening, and I think it'll take a little while longer, but it will eventually happen.
Great. So thinking more about exercise, this question asks, can we optimize exercise therapy to achieve the most effective exercise-induced hyperalgesia? Secondly, do you think the mechanisms responsible for exercise-induced hyperalgesia might cross over to long-term pain processing, we seem to have less literature looking at these long-term adaptations. Thank you.
So yes, we we are going to need to optimize exercise. At present, what we know is that being physically active, no matter what you do, is better than nothing. And we know that all the studies that have looked at different exercise programs against each other from a clinical perspective show equal efficacy. What we don't know is, does, for instance, this aerobic exercise have a different mechanism of action than resistance training has than, say, maybe a graded exercise program? If they're different mechanisms, maybe we could better optimize them based on the patient's underlying mechanisms and the mechanisms of the actual treatment. And so we're at earlier stages in understanding the mechanisms of action of exercise. I think we've done a really good job of trying to get a lot of mechanisms for aerobic exercise, and we know there's a lot of changes in the central nervous system. We know there's a lot of changes in the immune system. We know there's changes in muscle. Resistance training is very new, and there's really only a couple studies that have been published on resistance training and mechanisms, but they may be different. And so understanding how each of those is doing something a little different may help us to better target and better optimize it. And I think we're a long ways to knowing what is the best dosing for that and what are the best treatments for that. But I think we're getting there. For the TENS work, it took us, 10 years of doing basic science research before we could begin to take it to the clinic to optimize its dosing. And I think we're just in the stage where we're trying to figure out mechanisms right now so we can take it back and optimize dosing based on our understanding of how it's working. But it's actually a bit more complicated because exercise is so many different types, so many different parameters to modulate, a single treatment, multiple treatments. How long before you see an effect? How many days a week do you need to do it? How long do you need to do it? Which type is most effective, and what happens if I combine them? Different types. So we have a long ways to go on that, but I think we can ultimately do that. At present, I really just tell people to do whatever you can get the patient to do. So the most important thing is that they actually adhere to it and that they do it. And if they don't adhere to it, then you might as well just not give them anything. So telling someone to swim when they hate swimming, like me, is not going to be very effective. I'm never going to go do it. I hate swimming, but I'll go hike in the woods every day if I could. And so I think you have to find out what works for most people or for that individual on an individualized basis and get them doing it. And maybe we can begin to look at the other pieces. So exercise, we still have a long ways to go, but I think we're, slowly we'll get there. We need more people studying it though.
Great, so this adds in another parameter to this, but so this is a question about women, potential sex differences in pain. Why, could you kind of talk a little bit about why women have more chronic pain?
Well, that is a totally understudied area, but we're starting to think more about sex differences in pain and sex differences from a mechanistic standpoint. And some of our data and some from some others have shown that females, and these start in mice, so the female mice, it's easier to induce kind of a widespread pain condition and it lasts longer in them. And that might explain some of the reasons why females might have a little bit more pain than men. Some of the other converse is that we've been able to show that testosterone itself actually protects from developing kind of this widespread pain. So maybe men aren't getting as much widespread or chronic, longer lasting pain because of the testosterone. And in some instances, of course, if you remove female hormones, then that actually modulates it too. So it's actually quite complicated, but I think we're starting to see that there's different immune responses in men and women. There's different hormonal responses, and they may actually be condition dependent. So neuropathic pain might have different mechanisms than a musculoskeletal pain problem for why women have more pain than men. But, you know, every cell has a sex, and we don't think about that. So cell cultures, you know, you take the cells out of a female mice, they might respond differently than those from a male mouse. The females have sexes, and then there's probably some psychosocial issues related to males and females as well, and how they respond to things from a cultural standpoint. So I think it's a big open question, and there's a lot of research starting to come out on differences between males and females, and it is a really good area to go into and study. I think as we are now required by NIH to have males and females in all of your studies, whether you're doing humans or animal work, that should help to improve our knowledge of males and female sex differences. But I think there's so many options out there that they could be occurring at multiple sites, multiple mechanisms, and may be condition dependent.
So this is, I think it sounds like we have many PTs that are here live. This question is, how has being a physical therapist helped you as a researcher, or has it ever been a barrier? How do you kind of think about your...
Yeah, I think it has really helped me as a researcher. I think, and I mentioned this earlier, but I think just the time in the clinic and the ideas and the types of patients that I saw as a clinician drove a lot of my research and a lot of my research questions. It drove me to develop a novel animal model of pain that was not associated with tissue damage like I saw in the clinic all the time. It drove us to begin to look at TENS. I had students who wanted to look at TENS, so I said, okay, go ahead. And we designed projects, and we were able to begin to look at TENS and then figure out how to use it better. Same thing with exercise. I had students pioneer that work that were really interested in exercise, and it led us forward. And I think really thinking about I think the more knowledge you have outside the box, so I think it has helped me more than it's ever hurt me. I don't think it's ever really hurt me, actually, from any perspective. I would go to NIH study sections, and I'd sit on a study section and I'd say, I'm a neuroscientist and I'm a physical therapist. And people say, you're a physical therapist? I never knew that. That's really great. We need those in here. So I don't think it's really hurt me, but I think it's only helped. And it's really helped me focus my research questions and provided, you know, a really unique perspective. So everybody has their own unique perspective, but capitalizing on that is what I think we need to do.
Great. Okay. So then I also got a follow-up for this is, so what if you're a physical therapist without a university or faculty position? How would you recommend getting involved in research from that standpoint?
Oh, that's a great question. So if you're really interested in doing some research and I'm assuming you don't have a background in research training, but you're interested in doing it, I would reach out and get some help from someone like Ruth or myself or some physical therapist who's actively involved in research, and let them kind of talk you through what are the key components to doing this research project and how could we get it implemented into your clinic or into your system. And I've certainly done that with other people before. And there may be ways to capitalize on what you're already collecting in the electronic health record and ask some very simple questions that way. That would be really useful, but it's always helpful to take your ideas and have a sit down with somebody else and go through those ideas to really make them the best that they can be and come up with a really solid project. So I would really suggest reaching out, but there's no reason why you can't do research and you can't, and we need researchers from multiple perspectives, but getting a little bit of help along the way would be huge to making you successful at doing that and making it a quality study that you could get published in a good journal, which I think is what ultimately we'd want to do.
Great. Okay, so we're nearing the end. So I have one last question. That's great. This is from Dr. Erica Merriweather. Since we started with a question from me as a former postdoc, so Erica was here at Iowa briefly. We overlapped, and so this question is from her. So she's an assistant professor at NYU now. So many may not know that you have mentored and collaborated with scientists of different races, ethnicities, and cultures from around the world. Similar to the question related to better representation of women in science, what do you feel PIs need to do to facilitate recruitment and retention of diverse scientists in pain and rehabilitation research?
Well, that's a great question, Erica, and it is very similar to the woman question, and I do just think we need to keep our eyes and ears open. We need to have resources, we need to have support, and we need to have a welcoming environment that will bring everybody there. So what are the resources needed for a diverse environment? We need to define those. We need to have those resources at all our institutions. That should be institutional, but should be at the lab level as well, so that we make sure that everybody is fully supported to be effective. And it probably should come down to even getting a new assistant professor on board. What do we need to make them successful? It's the same thing for women. We know we've kind of figured out some of those resources for women, and now we're working on how do we figure them out for faculty of diverse populations, URM faculty and other faculty that need support. And we need to figure out how to do that, and that needs to come at an institutional level, at a departmental level, and then within a culture and an environment that is open and inclusive and welcoming. And so this is just something we have to keep our eye on the ball. And yes, we've had lots of people from across the world, across cultures in our laboratory, and I like to think that everybody is created equally, and they all have the same goals, and they all have the same mission in life, and it's up to us to figure out what's the best way to mentor that individual person through. And everybody has a little bit different mentoring needs, so an individualized mentoring program is probably the best way to go, but under the bigger umbrella of what you have at an institutional level to help support that. So it's all about resources again, and an environment.
Great. Well, yeah, thank you for that. And since we're nearing the end, Kathleen, do you have any final comments?
Oh, no, not really. I'm very, very happy to be here. I think that just anybody who's going into research needs to think about what your needs are and what your specialty is and how you can make yourself unique, and focus on what your strengths are and play to those. And if you need expertise in something else, reach out and get help. Collaborate as much as you can, because that's fun. Actually, it's more fun to work with others than not. But also with collaboration, you really can reach outside your comfort zone and do some things you never thought you would ever do. And I think about all the things I've done in my career. I could never have done them alone. I don't have those skill sets, but I have a skill set that I can build a team, and I can get the right experts in that can help me learn it, and we can put things together. So I would say from a research perspective, just reach out and collaborate. Always think about and in mentoring, I would just say make sure that all your mentoring is individualized to the person, that everybody has a unique need and unique strengths, and you need to capitalize on those to make them successful. And then lastly, I would say you should join the IASP because if you do join, there's a free meeting in June, even though it's virtual. And then you can attend the next one, which will be in Toronto in 2 years. So we're all, our next year, 2022, I can't remember. But it's a great opportunity to get out there and meet other people. There's all the forefront researchers go there, clinicians go there, people from around the world. You'll get to meet all kinds of fun people and have some really exciting conversations. So I would also just put a plug in for that.
All right, great. This is Neil here, just jumping in. So as we wrap up here on behalf of PRF and ISP, I just wanted to thank you, Kathleen, for a really fantastic session and discussion about such a wide-ranging collection of topics. So thank you so much. Thanks to you, Ruth, as well, for really doing a masterful job moderating all these rapid fire questions we received over 60 questions. So that was just a tremendous job. So thank you for moderating. I want to thank Anna Lombardo, my colleague at IASP, for her invaluable help behind the scenes to make sure these events go smoothly. I'd like to thank all of our attendees for listening to the seminar and for submitting your questions. We'll have a recording available probably by the end of the day or early tomorrow on the PRF and ISP websites. So you could take another listen, or if you have colleagues who might like to listen but weren't able to attend today, they can do so. Like to again thank our funders, the Mayday Fund and UT Dallas. And also, as Kathleen was saying, we encourage you to become ISP members. It gives you access to the virtual events. And then also next year, 2022, the Congress will be in Toronto. So we look forward to that. So with that said, thanks everybody for attending today. We hope you enjoyed the seminar and we look forward to seeing you at the next one. Take care. Bye-bye.